Good morning and welcome to the final day of the Enhancing Disease Investigation and Intervention Functions webinar. Next slide. So just wanted to go over the meeting rules for today. In the interest of time, we've minimized the chair function and we do not have a chat box. As with every other day, if you have technical difficulties, please contact Tony McDuffie at 240-614-9293. Next slide. So I'm Jamie Licklider, and I will be giving a summary of the meeting. Next slide. So I thought it may be most helpful to present highlights according to the 4 goals of the webinar, which are shown on this slide. And I had to focus on a few key highlights. As a result, I'm not able to do justice to any of the presentations this week. I selected highlights that I thought were important and met the webinar's goals, but many important issues and topics could not be included in this summary. Next slide. The first goal of the webinar was to discuss DIS, or Disease Investigation and Intervention Functions, to examine their effectiveness and to explore ways in which effectiveness and impact of DIS functions can be enhanced. Next. And I thought it would be useful to start with a reminder of the DIS activities roadmap that was presented early in the webinar. And as noted then, DIS functions can be very broad beyond the traditional partner services that we often first think of. But these may vary widely by program. Next slide. And although this webinar was organized by the Division of STD Prevention, it's important to note that the disease investigations are not just for STD, HIV, or COVID. We heard about New York City. However, many other state and local health departments also conduct investigations for numerous communicable diseases. Next slide. Additionally, according to a survey of state and local health departments, DIS do conduct other roles in addition to partner services. We found that DIS also enroll people into health insurance, provide referrals to mental and sexual health services, connect with primary care providers, and engage in surveillance activities. And as we've heard frequently the last few days, DIS also engage in emergency response and preparedness activities. Next. So further, in addition to standard field delivered therapy, we heard that DIS could deliver medication in different ways. For instance, DIS may deliver medications to provider practices who do not have a needed antibiotic in stock. Other DIS could deliver prescriptions, and others could, either alone or with a public health nurse, administer intramuscular antibiotics to patients in the field. Next slide. So given that there are over 1 million STDs reported each year, programs do not have the capacity to have DIS contact all index cases. And so in an effort to prioritize disease notifications other than syphilis, Pennsylvania examined their surveillance data and found that persons with multiple STDs were more likely to acquire HIV. So they prioritized these STD repeaters for disease investigation services to offer them PrEP, which in turn should result in more frequent STD testing as part of PrEP services. And of those contacted, 29% were already on PrEP, but they got another 28% referred to PrEP services. Next slide. And as we saw, research has indicated that more partners are notified when public health staff are involved. Next. However, the number of the persons brought to treatment may be declining over time. Next slide. And so why may the effectiveness of DIS be declining? Is it that there are too many STD cases? Well, that's likely part of the issue, but we also heard about the lack of community involvement in designing disease investigation and intervention programs, and how the lack of this misses a very important context in which behavior occurs. Next. And there are a lack of trainings that address soft skills. So a focus on human interaction and community engagement, as well as leadership skills and ethics. A focus on the entire person, their life, and the context that surrounds them is needed. Next. So for goal number 1, there were some issues that we didn't hear much about. The focus of public health is on protecting the health of the entire population. But there is a lack of information on how DIS functions impact population-level disease rates. Therefore, we need better studies of the role of DIS functions on population health outcomes to fully evaluate the effectiveness of these functions. Mathematical modeling could help with this. Additionally, we also lack data on the effectiveness of some aspects of DIS work, and research could help with this. Next slide. The second goal of the webinar was to examine recent digital and medical technology and consider how they may be useful for disease investigation work. Next. And so this goal was shown in two areas of a figure presented on Wednesday, focusing on the context surrounding DIS activities. Next slide. We learned many examples of new technologies and how they may help DIS work during the last 2 days. So I'm just going to give a snapshot of the following issues. And so methods to improve case report data to aid in contact tracing, automated and electronic notification tools, the availability of existing national and local data that can help our efforts. And finally, we'll focus on the testing and treatment technology. Next slide. So one important digital and data management technology is infrastructure that allows very quick synthesis of data from multiple databases to provide both timely and complete case report data. So open source technologies have helped with this as they have dramatically increased in response to COVID-19. They are useful because they are publicly accessible and can be adapted by the community of users. They do have some challenges, including integration with existing systems, and also getting the community to use and then sustaining the use of these tools. However, they can be useful. Next slide. And so we learned some efforts where improved case report data could aid more timely contact tracing. On the left side, the first example is focused on syphilis and features the use of open source code to pull EHR data to automatically fill in forms or create registries. This could provide more complete case-related and surveillance data to the DIS to use for timely contact tracing and for other DIS functions. And on the right side of the slide, the second example is from Maryland and was used for COVID-19. They matched index patient data to CRISP, the state's health information exchange. Within 60 minutes, enriched contact tracing records would be available then, allowing for timely attempts at contact tracing. Next slide. And so Maryland's process resulted in having phone numbers available for nearly all cases and contacts. Additionally, interventions were completed for 71% of cases and 60% of contacts, with approximately 60% of cases naming at least one contact. And this shows how receipt of timely and improved case report data can assist with successful contact tracing efforts. Next slide. And so we also heard about automated notifications to cases and contacts. And two examples are programs in Arizona and San Francisco, where they adapted existing technology for rapid use. Next slide. In Arizona, automated phone calls or text messages expedited case notification from 11 days to less than 24 hours, which allows for very quick, very quick possibilities for treatment and partner notification. Next slide. In San Francisco, the virtual assistant was helpful in getting through a large surge in cases and was particularly useful in reaching the target population, which is something we should think about with our efforts. Next slide. We also heard about other electronic tools, and I'm going to touch on only two examples. So CA Notify, which used the Google Apple Exposure Notification System, and Epi Contacts, which enabled index cases to easily provide accurate and complete locator information for their contacts. These tools can be attractive as they are inexpensive and simple way to notify cases and contacts. Next slide. But what about the effectiveness of electronic notifications and tools? Well, California used the system to supplement existing conventional contact tracing programs. They had 12 million activations, 30% of codes were claimed, and 13% were used. Next slide. And with the Epi Contacts tools, Almost 19,000 cases were elicited in 30 days, or an average of 623 contacts per day. That's a volume that cannot be matched using human resources to call and interview cases. Next slide. And mathematical modeling has also provided insights into the effectiveness of electronic notification. Research has indicated that the effectiveness of EN can vary widely across states, given the percent of contacts notified and the timeliness of notification. Next slide. Accordingly, the estimated cases averted also differ by locality, with some estimates showing minimal cases averted and other estimates showing a significant proportion of cases averted. Next slide. So another important issue is, how does use and satisfaction with electronic notification differ by subgroups? Two studies gave us an initial examination of what people think about Google app electronic notification. In general, the studies were encouraging regarding health inequities. However, it's important to note that differences were found within race. African American men with lower incomes were less likely to use the EN compared to African American men with higher incomes. And so we also have to consider that when designing programs. These data are really useful, but more information is needed over time and with other populations. Next slide. So we also learned about the availability of existing national data from Google searches for symptoms, signs, and diseases. Next slide. These data can be especially useful for other geographic areas, such as the state and county levels, as one measure to evaluate our public health intervention efforts. Next slide. So regarding testing and treatment technologies, we heard about a partner services program that delivers some home-based care to hopefully reduce health inequities in HIV prevention. The goal is to reach the highest priority in underserved populations. The program included STI self-collection kits, a virtual visit with a provider, and immediate HIV treatment or prevention that's delivered to participants at their home via field services. Next. Rather than having contacts go to clinics, they are told that they can have a telemedicine visit and immediately begin HIV medications. So this type of program does require a clinic who will collaborate with partner services efforts. Next. The program had some promising findings, including higher uptake of field-based HIV testing, beginning PrEP immediately without having to go to a clinic, and also universal acceptance of field-based STI testing. Next slide. And the COVID-19 pandemic did not stop the program. Instead, it was changed to rely more heavily on telemedicine and the delivery of testing and treatment at home. Next slide. Finally, we also learned about novel technologies that were used to develop rapid tests that may be useful for disease investigation and intervention, particularly for timely identification and notification. Next slide. But we also learned that for some diseases, testing technologies are needed for different situations, such as ruling in or ruling out infection. And sometimes technology that is easy to use is the best option, depending on the circumstance. Next slide. And as we know, point of care testing could greatly aid in disease investigation and intervention. And the good news is that we heard field-based testing technology should be providing more testing options in the near future, which would help with timely case detection and hopefully in timely treatment to halt disease transmission. Next slide. So for goal number 2, we heard a lot about automated and electronic notification, but there were some things we didn't hear. First, although privacy is a key function of electronic notification, we know that some people are less likely to trust government and big businesses. And so how does this lack of trust influence uptake and use of EN systems on cell phones, even though they're completely anonymous? Also, states have had varying levels of success with EN, and it's important to examine local differences as well. Finally, we heard a lot about electronic tool use by subgroups, but more information would be helpful in determining what technology is acceptable to which subpopulations under what circumstances. So an important question to ask ourselves is, who are we missing when using these technologies? And that's not to say electronic notification tools are not useful. They are likely incredibly useful. However, they are only one tool in the disease investigation toolbox. They do not replace traditional disease investigation, but may complement it. Next slide. Regarding medical technology and what wasn't covered, I'm simply borrowing a slide from Laura Bachman on the possibilities for field-delivered treatment. There are some questions that we need to ask ourselves. We have to think about the safety issues related to field delivery of medication, what STIs would be targeted for this, what training needs do DIS have to deliver medications, and whether or not all DIS will be comfortable administering treatment, even if they're trained to do so. Next slide. So the third goal of the webinar was to describe the organizational context and structure of DIS teams, and to think about whether organizational changes may increase the effectiveness and impact of disease investigations and interventions. Next slide. So the organizational structure and context of DIS teams was also included in the figure that was shown on Wednesday around the context for DIS activities. Next slide. And there are two things I want to talk about in this section. First, the organizational structure for DIS, but also something came up, which was the qualities and characteristics of DIS. Next slide. So we saw a couple of examples of organizational structure and how DIS teams are organized. Kentucky has 120 counties, but they only had 8 DIS. Now they said they have 11, and the DIS are located in high morbidity areas. They do hire DIS from within the local community, so they are familiar with the community itself. Next slide. And in New York City, they use public health epidemiologists who are located in the general surveillance unit. They are assigned to cases by geography. Next slide. But during COVID-19, we saw both new emergency response structures for disease investigation work. Next slide. And given the large volume of cases, we also saw the need to complement existing staff via contracts or collaboration with partners for case interviewing and contact tracing. Next slide. So one example of expanding DIS through partnerships was Chicago's COVID case investigation contact tracing, which is CICT. It's a multi-sector model to manage the volume of cases and promote health equity. The model included 3 groups: Chicago Department of Public Health employees, healthcare partners, and community-based organizations. Next slide. And they found differences in the percentage of cases interviewed and contacts notified by organization type, which is a really important metric to assess for our current and our future work. Next slide. So one of the overarching focuses in Chicago is Healthy Chicago 2025. And one of the focus there is to reduce racial inequities in life expectancy. Therefore, reducing health inequities was built into CICT as well. And it's important to note that team members who had racial and ethnic characteristics similar to communities most impacted were involved. Next slide. So San Francisco also noted the importance of individual qualities that DIS need to perform their roles, ranging from syphilis expert and detective to teacher and therapist. So there's a wide range of qualities needed for DIS. Next slide. So for goal 3, we heard about some structures and activities of DIS programs. However, we didn't hear much about the optimal organizational structure for DIS, and this topic needs additional attention in order to address how structure may impact DIS functions and influence population health outcomes. We also didn't hear much about community engagement in DIS work, which may be important for work in the communities. And one topic from the panel discussion that is of importance here was to think critically about structure for DIS. Perhaps rather than having them grouped together in the same unit, we may want to think about a more holistic approach where we would have DIS assigned to interdisciplinary teams that could help increase their knowledge, skill, and effectiveness. Next slide. So the fourth and final goal of the webinar was to assess the role of rules, regulations, accountability, cost-benefit considerations, performance metrics, and outcome assessments as they shape DIS functions today in the future. Next slide. And this multifaceted goal was also represented in the contextual roadmap. Next slide. So first, regarding rules and regulations, we learned that authority for disease investigation is primarily a state issue. There are multiple policy levers that can be used, including legislation, regulation, and internal processes and policies. Next slide. So while authority for STD investigation was universal, there is significant variation across states. So it's important for everyone to understand their authority and also to identify opportunities to enhance DIS functions, including thinking about things you're authorized or required to do, but not really equipped to do. Next slide. And we also focused on funding and accountability. Accountability is important as public health programs use taxpayer dollars and must prioritize public trust and confidence. We answer to the public. Accountability is also central to improving equitable access to public services. Next slide. We also learned the importance of cost-benefit considerations. It is useful in order to maximize a limited set of resources while achieving a health target. Next slide. So although costs can be difficult to measure in some cases, such as long-term outcomes, there are other things we can do. The population level effects of policies may be estimated and could serve as a useful metric. Next slide. And as we heard early in day one, there are increasing cases of STI and declining partner services outcomes. So the performance measures we select and use are incredibly important. Next slide. There are multiple measures of performance and outcomes, including process and clinical measures and population level outcome assessments. Next slide. This slide shows some of the traditional process and clinical performance metrics, as well as population level outcomes. And although current metrics are good measures, they're not good enough as they do not include what was missed by syphilis partner services interviews, and they are also not linked to population health outcomes. Next. So what's commonly missed are the partners who were unnamed and those who were not reached for partner services. Next slide. Some current performance measures may also include persons who would have been treated without DIS contact. Next slide. Also, current metrics often exclude other important work by DIS. So we've had several examples of this work presented throughout the week, and there often aren't measures for those things. Next slide. So we heard a lot for goal 4, but there were still some things we didn't hear. First, we heard about multiple approaches to accountability, but we need information to determine the best measures for this. Additionally, we heard about the legislation focusing on DIS work. However, we really lack information on the informal processes and policies that may really guide DIS work. And over the past 2 days, we heard about how to enhance and expand functions of DIS. But we know it's not possible to have DIS implement all of the new functions that have been covered. So it'd be helpful to know what activities are most effective and cost effective and in what areas. But we did hear how difficult it is to parse out the costs of various DIS activities. And we had a lot of information on performance metrics that are useful and what's missing, but we really didn't hear about an ideal set of performance metrics that would be useful for DIS activities. Next slide. So finally, I wanted to highlight just a few recurring themes that may be important to consider in your work. DIS are required to serve in very diverse roles. And while current trainings exist, trainings on topics such as soft skills and even refresher trainings are probably needed. We did hear a lot about training, and so we wanted to mention that our next webinar will be on DIS recruitment, training, and retention. Also, there has been a lot of information presented on the enhanced functions for DIS. Not only isn't it possible to do everything, one size may fit all. So data may help show us what works best with what population, where, and at what time. COVID-19 has provided us with new technologies that may be useful complements to DIS work, and hopefully more data will be available soon on the effectiveness of these tools in specific subpopulations. Next slide. So obviously most of the work I presented was not my own. Therefore, I owe a big thank you to the speakers for their excellent presentations and ideas. I also want to thank Sevgi Aral and Patricia Jackson for talking with me about my ideas on how to summarize this meeting. And finally, I should note that I did express some opinions here. And so anything I said does not represent the official opinion of CDC. Our next session is a panel discussion moderated by Sevgi Aral.
Thank you, Jamie. Huge thanks for a fantastic summary. I don't know how you can do it, but you do a great job. So our next session is a panel discussion, and our panelists include Laura Bachman, Ryan Kramer, Tom Gift, Jody McLean, Raul Romaguera, and Melanie Taylor. I would like to start. Maybe we can go to seeing the faces of everybody. That would be lovely. Thank you so much. I'd like to start by, clearly accountability is like where we start and we end up. So Raul, I guess you will be my first respondent. And the question I want to pose to you is, so you talked about improving program performance and program impact. So for accountability purposes, which of those should we be focusing on? Should we first focus on improving program performance, or should we look at program impact on population level health?
And thank you, Sevgi, but I'm going to give you my personal opinion. I think we should be focusing on impact, but I think we don't have the right measures to actually assess whether we're achieving program impact right now. And then, of course, because we have all of the different functions that DIS could perform, we'll have to see this out exactly what we expect from these DIS functions, and so that we can attribute the work they do to the program impact. So I think there's a lot of work that we still have to do to determine how best to measure it, and also how to identify those DIS functions that are contributing to program impact.
Thank you. I guess we could just take the next hour discussing just program impact and program improvement. But let's move on. Rules and regulations are things we don't usually talk about on a daily basis, but they are very important because they kind of shape what happens with DIS and what services DIS can provide the community. And we learned from Ryan that these things are highly variable as you go from jurisdiction to jurisdiction. So Ryan, my question to you is, are there programmatic advantages of having broad as opposed to narrow authority for policies authorizing DIS? You have been studying the variability. What do you see?
Yeah, and so, through my talk, what I was really getting at was that some states are very prescriptive in terms of sort of laying out exactly what a DIS investigation should look like and in what circumstances, and then other states sort of provide more discretion to the health department how to do this. And so I think the answer to whether sort of this more specific prescriptive authority or the broad authority offers programmatic advantages, I mean, the answer is maybe. It sort of depends on what the policies actually say. I think that more than anything, it sort of changes how you approach the problem. If you have more specific authority, it sort of leaves less to the imagination. You're just sort of going down the list in terms of what your rules require you to do. But it obviously depends on what your policies say and also where your rulemaking authority really lies. So if there's gaps in your abilities to perform your DIS functions, is this an issue that needs to be taken up by your legislature, or is it really within your health department authority? So, if it's your health department, then this is really an issue of educating your senior health department leaders and sort of, making this issue a priority, right? Like the sort of empowering your STD program to be able to meet these critical functions. If it's the legislature, it might require some education, which might be harder. Every state has a process for executive, legislative branch relationships. And of course, if your health department is the recipient of federal funds, you need to be aware that there are anti-lobbying rules that are associated with these funds. DSTDP is available for assistance with this. So if instead your health department is your authority is more of the broader variety, I think this is sort of where you want to be. It's sort of a recognition of your subject matter expertise. It might provide you with more latitude to implement DIS functions as you see fit. On the other hand, it kind of puts you in a position where you can always be sort of reasonably confident that you have the authority to do what you need to do. But reasonable minds might differ on this, and where it's just sort of broad. So I think of a situation where you have turnover in your leadership of your health department, or other leaders in your state outside of your health department. Like what happens if they disagree with some of the finer points of what you're doing? In that situation, it might be nice to have some more legislative clarity, like hey, here's our list of things we have to do, and we have to do them. In the absence of that, you're sort of left with a situation where I think you need to have your justification ready. This is what we're doing. This is what our authority says. This is really what my talk got at, just to sort of understand like what you're supposed to be doing as the health department. Explaining why like these functions are essential, and why not doing them would cause your program to not meet your responsibilities to your state. So I think the answer really is that it depends on the circumstances, and it really underscores the importance of understanding your policies and your state's culture and your environment for public health.
Given how variable these things are and how much it depends, can you please repeat that golden sentence? DSTDP is ready to assist with this?
We are very much available for technical assistance on all these matters, yes.
So we are talking about rules and regulations, and of course, those interact very intimately with training and skills and abilities. And we are very much looking forward to enhancing DIS functions. So my next question is actually for Laura. Laura, what background do you think will be needed or is needed as we speak for DIS to be able to administer and deliver treatment, medical treatment?
So I don't think that's entirely, does not have a clear-cut answer at this time. And it, again, would vary by the jurisdiction. I did notice, in talking to people, there is, again, a lot of variability there with how creative one can be about training individuals who perhaps don't have the medical background to do treatment. And so to the point that Ryan was being asked, there is more room for creativity when there's a broader interpretation, but then at the same time, obviously there needs to be, standards that I think all of the people listening to this are tried to achieve in terms of how they deliver certain services. But it's, for sure, people can be trained to do certain tasks or administer medications who don't have the medical background. But I do think that, there are potential adverse events that can happen with medication administration. And in particular, certain medications may be more likely than others to have these adverse events associated with them. And while rare, I believe like true anaphylaxis to penicillin, for instance, is probably 0.01% of the cases that we treat. Having the standards in place, I think, are important, and that would be involved, of course, the rigorous training of people who are administering therapy like this, but also thinking through all the trouble spots that one could encounter in the field. And that is something I did notice with people who had, they do have protocols in place in terms of thinking ahead of, okay, if something happens, what are we going to do? Can I make, do I have cell service? Do I, is there a place nearby that can respond and those sorts of things? So I think all of that will need to be, does need to be thought through carefully, whether it's an oral medication, which is, I guess, would be less of a concern than an IM medication. But so it's hard for me to say that a certain, only like a certain training should be able to do it. But I do think that if it's not someone with a medical background, the training process should be very standardized and rigorous with all these safety and methods in place. I mean, during the COVID pandemic, I think pharmacists have given millions of IM injections at this point, right? So I'm not saying you have to be a physician or be a nurse, but just that I think we probably need to give some thought to, and we can learn from those who've kind of gone ahead to the standards that we might want to have and the training that would be needed. And again, it's also going to, it will depend too on the comfort level of the individual because they will need to be comfortable with the situation. And then thinking about probably having more than one person out there in case something did happen. And, then that gets into how cost effective is it and which situation should be the, this more, I don't want to say aggressive, but, just this method be employed, like how would you target it? When does it make sense? And what are those cases? I mean, for sure, congenital syphilis, that's an area that, we're really concerned about right now. And we have major barriers to access some of the pregnant people getting into standard clinical situations. So I do applaud the programs that are thinking really outside of the box here at how we can, deliver these services to people who can't come through the standard or routine clinical process.
Thank you. And it would seem to me it's not simply a training the individual kind of thing. It's also the system the individual is in and what kind of backup support the system allows, right?
Right.
So we will have to study both the training requirements and the system requirements.
Yeah.
Thank you.
Good point.
Thank you. So, I mean, all of these questions that COVID made us think about. And of course, that brings us to the central question, Melanie or Jody? I am interested in going into a little bit what we are learning from all these technologies developed for COVID. Are states, jurisdictions adapting the technologies developed for COVID to other communicable diseases, specifically to things like STD, HIV, and other communicable diseases?
Yeah, it's a good question. And I think both of us will have, it's nice to tag team with Jody because we have different perspectives on this. I think that what we can say is that health departments are still inundated with COVID. And many of them have not placed as high a priority on STD intervention and surveillance during this time. We know from our surveillance at the CDC level, I think that even case reporting might be compromised by the need to divert staff and resources to the COVID response. But we do know from the presentations yesterday that there are jurisdictions that are looking to adapt some of these surveillance systems and disease intervention enhancements to other infectious diseases, including STD. So that, for example, Maryland yesterday mentioned that they're considering adapting, and they have one of the most complex and I would say wraparound systems for digital surveillance of any of the programs that we've seen through our contact tracing and innovation section work as part of the COVID-19 response. And I think what we think is that the opportunities are there. There is quite some interest, but we don't have a lot of on the ground data to say that they have been able to work on the adaptations that would be required to use these systems for STD. I think we do know that a lot of our STD programs are using somewhat outdated systems or systems that lack functionality to be able to link through and interpret or to input some even electronic laboratory reporting. And definitely the opportunity to provide less than 24-hour notification of a positive test result is not available in many jurisdictions for STDs. And these are some of the technologies and adaptations that would greatly benefit the disease intervention process for STD. So I think those are some of the opportunities that we see. But again, I'm not sure, Jody, if you want to comment on where programs are, but I think that COVID is still front and center.
Yes, so building on what Melanie said, from watching and listening over the last few months, I would say that it seems like we're doing Band-Aids in our contact tracing systems when it comes to digital innovations, because you have a workflow and people are using different systems at different parts. And especially when listening to Resolve to Save Lives, it seems like you say we're doing Band-Aids and we need emergency surgery. And I think COVID has helped highlight the integration issues that we have, and looking at the cases of states that have successfully integrated their systems, which is going to help with, as Melanie stated before this meeting, on coverage and timeliness in the long run. So I think COVID has highlighted the issues that we do have, and there's an opportunity to build an integration and to really do that emergency surgery, overhaul integration, and ask that of our vendors that are doing technology for us. I think that's going to be the long-term benefit of COVID.
And all of these adaptations are going to further widen the functions of DIS, right? And we already have difficulty trying to conceptualize and evaluate and deal with all those enhanced variable functions. And my next question is going to be for Tom Gift. So all these variable enhanced functions of DIS, how do we, and all of their indirect benefits for community health, how can we include all of these considerations in doing cost effectiveness, cost benefit types of analyses?
Well, it's sort of a canned stock answer, but one of the first steps would be more data. I think a lot of programs probably have some of these data at some level, but they may not have been analyzed systematically. And one of the examples from the discussion a couple of days ago is linking partners that they locate in the field to, say, substance use or mental health services. They may have a log or something where they know what those numbers are, but if the numbers can be analyzed, there are other literature sources that could be used to translate that into something of a concrete benefit. You know, if it's a passive referral, it's not going to be terribly effective in terms of uptake, but it might be 1% or 5%. I don't know the literature there myself, but there'll be some sort of a benefit there, and there will be incremental increases in health that are resulting from the DIS activities. So trying to get a quantification for as much as what they do as possible will be helpful. Also, other literature are useful for a lot of things. There actually is a established literature on the cost effectiveness of health insurance, for example. I mean, that was one of the motivations for the Affordable Care Act. We don't necessarily use those references in the STD world, but they are out there. And so linking people, navigating them to health insurance has an additional benefit. And a lot of these things, I mean, to some degree, linking someone to health insurance is sort of an ancillary benefit, but it's not the primary goal of the DIS, because many of them may view their mission as being primarily STD focused. If they can do these great things along the way, that's nice, but pulling additional bits of data in will help to justify the case to demonstrate the true health impact that they have. And then for indirect and broader effects, we've done some population level modeling, and there are other sources out there that will suggest the impact on community prevalence from DIS activity. You treat partners, therefore they don't transmit, therefore that ends up being a reduction in disease. And everybody wants to find those highly connected nodes in the network, take them out, and you have a big impact. But a program is not going to be able to measure community prevalence in that way. Falling back on the literature can help. And then this is an area where getting some of those more distant and indirect effects, literature from other fields will matter too. I've had conversations with Matt Golden about the impact of infertility in later life. And it turns out there is a literature out there. They're more likely to need institutional care, for example, end up in a long-term care facility. That has a direct cost, a direct medical cost. We have tended not to incorporate those types of effects, but they do have an impact on quality of life and also on direct medical cost. It's going to be far into the future, and so when you discount it down, it's not like partner services for every chlamydia case will suddenly become cost-effective. But it will have something of an impact and on your overall cost effectiveness ratio. And when you incorporate those things, you start to see broader benefits that touch other fields of healthcare way beyond STDs.
Thank you. Talking about benefits, I'm going to turn back to Raul. And Raul, I don't think you're going to be surprised. You know, I'm always going to ask this question from an accountability point of view. What should we be focusing on? Individual level benefits or population level benefits? I know you're not surprised that I am asking this question.
No, I think, Sergey, the difficulty we have when we talk about DIS functions, especially now that we are exploring the possibility of expanding the DIS functions, is what are we really going to be focusing on when we measure impact? Are we going to be focusing on the DIS separately from the STD prevention program, or are we going to be focusing on STD prevention program? And like Tom just pointed out, DIS are now helping not only STD prevention programs, but they're also helping substance abuse linkages, mental health linkages. We know DIS have been working extensively on COVID and like in the example provided from New York, in other communicable diseases. So how do we separate the impact that these DIS are having in public health overall versus STD prevention program? And I think that is the challenge we have with the accountability issue. So ideally would like to measure population health impact, but are you going to be focusing only on STD metrics, or are you going to be identifying other metrics that are also benefiting from the work DIS are doing? I think that is the challenge we have with accountability. And I would like to hear from others, because I think at a national level, it would be very hard for us to come up with some measures of accountability. I think we need to let that happen at the local level, where they're defining what are these enhanced functions DIS will have, and how those functions are benefiting not only STD prevention programs, but the overall public health program in that community.
Yeah, it seems like we have to do much more work on performance metrics and see what kind of metrics lead to what kind of evaluation. And something Matt Golden has said during his presentation is going to make this even more difficult. I heard Matt say we have to think about public health as a gestalt, and we have to think about the DIS functions as a component of that gestalt, which rings very true to me. But then if we think about evaluating performance, the problems you have just voiced, Raul, are going to be multiplied with that kind of approach, which is necessary. We have our work cut out for us.
And Sergey, if you may allow me, we cannot do this in isolation within the STD program. We'll have to reach to the other parts of public health that are benefiting from the DIS work.
Yeah. So, and of course, we do all of this within the context of, within the boundaries defined by rules and regulations. And I have also heard, not necessarily during this meeting, but as I was doing all the interviews in order to come up with the structure for this meeting, I heard repeatedly the rules and regulations we have sometimes stand as barriers to us, DIS, doing innovative, creative, enhanced type of work. And I'm going to turn to Ryan again. If the rules and regulations are barriers to creative, innovative work, what are the states to do, Ryan?
Yeah, so I think first and foremost, just to sort of take a step back, I would encourage you to lean into your expertise and your role as experts and leaders in this field. Embrace that role, be engaging. People will listen to you, and you need to be ready to explain, you know, why this work is important, why it's necessary that that you do it the way that you need to do it, and whether that be innovation or you know, customary practices, and really how it helps your jurisdiction, the value that you bring to your jurisdiction. I think that also when it comes to STD prevention, STD investigation, it's important, right? We've now committed a third straight day to this, but especially investigation is largely out of the public view. And so to your audience, this value might not be immediately obvious. And so you are the champion, embrace that. On the other hand, I think that things like contact tracing have really come to occupy our collective consciousness during COVID. You know, read the news, look how much this has come up during this meeting. So I think that the door might actually be a little bit more open to these types of conversations than it usually is. And so I think you have a few options. It really begins with a strong understanding of your policy environment, like from like your program's perspective. So that's really what I wanted to try to emphasize with my talk, that a strong policy understanding in this area really is possible. It's an accessible area of law. So I think that this helps you frame your request correctly. So I think it makes your argument easier, like, you know, when you know what you're asking for, like, what do you need to be able to do? What exactly is the policy problem, and what's the solution? It makes your ask cleaner. So, and I think to help all of this, I would really strongly encourage everyone to consider joining the NCSD Policy Academy if you're having these types of issues. It's a really outstanding program that is intended for this very purpose, improving the policy capacity of state and local health departments and supporting its STD work. So along with NCSD staff and other jurisdictions that are experiencing similar issues, you know, you'll learn basic policy analysis, how to appropriately engage with stakeholders, and so on. And it's really been quite instrumental in addressing many similar policy issues across states in the STD field. So.
Thank you. Talking about rules and regulations and enhanced DIS functions. One of the enhanced functions we have, I know all of us have thought about, is testing in the field. And I'm gonna come back to you, Laura. So if there is field testing, how do we deal with the requirement of reporting?
Well, again, I think it depends on how that testing, or if it's testing or self-collection, that distinction, which Dr. Vanderpoel actually made a point of making that distinction yesterday, which is important. And that is that currently, unfortunately, we don't have a home-based test for STIs right this minute. But we do have the ability to collect specimens in the field. And so if specimens are being collected in the field and being sent to a lab, then the lab really should be reporting. But I guess, or the provider could, you know, also that's a dual type of reporting that can take place. I think the real challenge is going to be when we do have a home test, which we hope will be, you know, in the near future. But and that's, if I knew the answer to that question, I don't think anyone has this figured out yet. I was encouraged to see what has happened with COVID, which, you know, with some of the tests and how it has been built into the test to report. and even denominator data, if I understand correctly, which is always something in the STD that would be interesting to have. But I don't know that we have those solutions yet. But I think that, you know, it either would need to be built into the technology of the test, or pull something from the medical record if treatment is given because of a home test. But if you rely on providers to report, unfortunately, as a provider, I'm a little pessimistic about that. I mean, we know how providers in general don't do a great job with reporting. And so if it came down to needing to report, for instance, what treatment was given for, say, gonorrhea or chlamydia or syphilis, then it would be important to have technology in place to extract that from the medical record. And there's a lot of people at this meeting that presented. They're a lot more fluent in that language than I am. But there is a distinction there between, I think, if it's actually a home-based test that the person's doing on their own, versus even if it's a home-based test and a DIS is involved, for instance, then perhaps the DIS could take the lead on helping to get that case reported. But it's when that patient is by themselves doing their test, I think that we haven't figured that out, and we're hoping technology is going to give us an answer there.
It's intriguing. Can you unpack just a tad? You said having the technology built into the test.
Right.
Actually, reporting, if you can say a sentence or two more about that for people like me who are not in the medical field.
Well, we're also talking to people like me who's I'm not fluent in technology. And I'm looking, I've got, maybe Nanad can correct what I say later on during the Q&A, but that translating the results of the test into the language that can then, I guess, go into the lab reporting system. That's my simple way of putting it. There's a lot more behind that than what I'm saying, but I think with some of the COVID testing that's taking place, that it seems that is being that is actually possible already, and then there's, I guess, privacy concerns that may be, of course, more pronounced even for the infections that we're talking about today, just because of the historic stigma that we have with those infections.
Yeah. So much innovation is happening, and so much more needs to happen. How are we going to distribute all this innovation? How are we going to disseminate all the new know-how? That in itself is going to become a scientific question. And so I'm going to turn to Melanie. With these newly developed, Melanie and Jody actually, with all these newly developed technologies, which are so variable across different jurisdictions and states, are there ways in which states are learning from each other? Have we created a system which would support dissemination of all these innovations? Either of you, just jump in.
I would like to go first, just because as the lead of the ITT team for a while, we had a community of practice meeting for exposure notifications for states that were actively using it and onboarding it. And that was bi-monthly at the time. And we had all the partners to help them. So Google, Apple were on the meeting, APHL were on the meeting, Linux Foundation to help answer questions and provide resources. The meeting was about an hour. Sometimes we had presentations. It's also confidential. So it was a way for people to share as openly as possible about the issues they're having, especially for a new technology. I think it's good to have a space for people to really dig in, and the states to also help each other and answer each other's questions. So I thought that was really successful because with new technology, there's so many questions, so many unknowns, and there's not publications because everything is brand new. So that would be my main example of a good use of a community practice meeting.
And then just to
Melanie?
add to, just to add to what Jody was saying, some of the speakers that we had yesterday, for example, Resolve to Save Lives, they actually have a monthly forum where they discuss with partners and other stakeholders the use of the tools that they've developed, the application, the integration, and the connection within existing systems, so that they can offer assistance, technical assistance to share practices and also to provide technical assistance to jurisdictions that are looking to expand. Similarly, Google offers their assistance to collect information and provide feedback to jurisdictions in the event that they would like to use some of the Google services and platforms and develop specifically case studies and also opportunities to work with other collaborators to gain information that is collected by Google that can be used at a local level. And then as Jody mentioned, the Linux Foundation, they are going to be putting together a forum that's dedicated to disease outbreak and investigation, and specifically for tech-related opportunities and tools that can be used to speed up the process, improve coverage, and again, improve that timeliness of disease intervention. So I think what we want to consider is that the opportunities to share information are not just across programs, but they are also across some of our very, very prominent and dedicated partners that I would say in the past, perhaps STD has not taken advantage of, but they are ready and they're willing and they're very much interested in hearing from states who would like to adapt some of these digital tools and technologies to other infectious diseases. And so it does seem like if there is a silver lining to be considered from COVID-19, that it is an opportunity for STD to move into more of the modern digital age, such that surveillance systems can be improved and at least enhance the work of the staff on the ground. And so this is, I think, in addition to what Jody said, there are opportunities for states to share their experience as well. And those forums likely need to be generated for digital tech and in relation to STDs, and that we might have a little more time to hear from states and jurisdictions this afternoon in the QA session, and perhaps even after the meeting to help to facilitate the exchange of ideas across platforms by the jurisdictions in some type of information sharing forum. Thanks.
Wonderful to keep talking about all of the innovations and how we are going to disseminate them and we're going to enhance DIS functions. But the more good news we focus on, the more I keep thinking about performance metrics, which will have to catch up with enhanced functions. And of course, the one thing which we seem to be talking about the least, and that is economic analyses, cost benefit, cost effectiveness analyses. What I'm kind of getting, and I may be wrong, Tom, please correct me if I'm wrong, but it's almost like we have no data on outcomes. We have no data on costs. I don't know how much we know about effectiveness, but performance metrics kind of suggest perhaps not too much. So given all that lack of information, how do we do economic analyses?
Well, I think that there probably are data streams that we can access if we start thinking about it. But when you're trying to block out a cost effectiveness analysis and go about analyzing something, particularly if it's a new intervention a program hasn't done before, such as field testing, the program might have no idea at the start of it how effective that's going to be at bringing people to treatment and finding people who are infected. But modeling, you can step out what the variables are that are relevant in determining whether it's cost effective and effective, so both outcomes and costs. You can block that out to begin with and do a sensitivity analysis and see which variables matter. One-way sensitivity analyses are not necessarily terribly informative in terms of robustness of a model, but they do give you a sense for where you need to focus your data collection efforts. And it may be that you can then find those variables that really matter and will determine whether your new program is successful or not successful, and find similar studies that may have some ranges for that, and you may be able to narrow the ranges. So in this case, the model is not necessarily the answer, it's to guide the data collection efforts. And then focusing data collection efforts on those areas that are most important. A lot of those process outcomes, I didn't mean to suggest that economists only care about the end result. Tell me how many cases of syphilis you treated. I don't care about anything else. Because oftentimes those process points, process outcomes, they'll have a big impact for cost. If someone shows up in the clinic, they're going to incur costs for the healthcare visit and the testing, whether or not you find a case of the disease at the end. So just getting the endpoint only doesn't give you the whole answer. But a lot of times when you're doing a cost effectiveness analysis, some of the process outcomes may not really matter in terms of workflow or other things that the program would necessarily care about if they're overall evaluating program effectiveness, but then they will have an economic impact. And so a discussion, it's sort of a two-way discussion over what data points are important and how realistic is it to collect them. A lot of times we can find ourselves stressing over something that's not going to matter much and it's going to be very difficult to collect. That stuff we can just go with an uncertainty range and call it good.
So cost effectiveness, performance evaluation, I think it all kind of feeds back into accountability. And if we are evaluating performance, Raul, I'm going to turn back to you again. So if we are dealing with accountability and trying to clearly define accountability, and if we are going to base it on evaluations, which we have to do, then of course, we beg the question, what are targets for DIS functions? Who sets those targets? And at what level? I mean, should that be at the level of the individual DIS? Should it be at a higher level? What level of responsibility do we need to attach these targets to? So targets, who sets them, and what level of responsibility, at what level of responsibility should the targets sit?
You're asking a very difficult question, Sergi, because we know that, as we have been discussing in this meeting, that DIS are actually supporting many programs. They're actually asked to support outbreak investigations. So to develop targets at the federal level, I think would be unfair to anyone here. I think targets for DIS should be set at the local level, and they should be set not only based on morbidity, and in this case, we have been talking about STD programs, but I think we already established that DIS support many other communicable disease programs. So we need to also account for all of those other activities that DIS will be performing on. And then lastly, we need to think about community needs. So it's not only about STD program needs. Remember, accountability, we are accountable for communities. So I think it's local, it's not only a national issue. So I don't even know where I would start developing accountability for DIS work at a national level, because I think it's all coming down to what's happening locally. And we need to be working with maybe set up a process that we could actually recommend to local jurisdictions in setting up accountability systems and also setting up targets. But I think it's something we haven't done in the past. We have been focusing on performance. We have been focusing on productivity of DIS. And so I think we need to take a step back and look at how we can hold ourselves accountable for program outcomes.
So given that DIS have to work in teams, given that, going back to Matt Golden's observation, these teams have to be a component of public health as a whole, rather than functioning independently. We really have our job cut out for us. We will have to think very differently about performance evaluation, accountability, targets, and at what level those targets need to be set. But I'm not going to do any further questions because I think we are getting really deep into this stuff. So let us see. I think I'm afraid I am going to go back to, talking about enhanced functions. One thing which has been very much on people's minds recently are issues of contraception, family planning, etc. And it has been suggested that the DIS could be helpful, at least with referrals in this domain. So I'm going to turn to Laura again. Do you think the DIS could be helpful in terms of linkage, creating linkages to the system for contraceptive services? And what are your thoughts about that, Laura?
I mean, I think that they could be for sure. And in my conversations came across, this I think is on the minds of some the programs as well. I think just going back to my memory from my some of the talks I had, California, for instance, I think is looking at using pregnancy testing in like homeless, in situations with homeless people to try to, again, address congenital syphilis. So sorting out if an individual's pregnant as early as possible to expedite treatment. And so, pregnancy tests are over the counter. And so that's, a patient can perform the pregnancy test even themselves under, with DIS supervision, or, there's a lot of different ways I think you could go about that. And then that could triage either to prenatal care or to, contraception, if the individual's interested in that. So I think there's several different ways to go with that. But in some ways, since that pregnancy test is over the counter, it may even be less of a barrier than some of these other scenarios that we're talking about where, we don't have other home-based STD tests at this point. And even sometimes when tests are CLIA waived, depending on jurisdictions, DIS may or may not be able to perform the test. So, I think this is an area, and again, getting at, not that pregnancy is a syndemic infection, but it is a condition that we run across frequently. Individuals who need to, be at least aware of options, contraceptive options. So I could see DIS playing a role there. And again, it would involve more training of, DIS just to have some kind of fundamentals of the different options out there, and that would vary based on their locality, but also just some basic concepts too around contraception. But I personally would see that as an area that could be explored further.
Thank you. Again, enhancing functions and innovations. We have all these new technologies being developed for COVID, and let's hope jurisdictions and states and STD HIV systems are going to adopt all these new technologies. So Melanie and Jody, how do we deal with the other side of this equation? Once these technologies are adopted, how are we going to evaluate performance with them? How are we going to evaluate their impact at the population level as we are trying to evaluate the program as a whole?
I think it's interesting, and I'll start and then I'll hand it over to Jody. What Tom was saying earlier is that we first have to decide what our measures are. For regardless of the enhancements of the interventions that might be used as digital tools, we first have to figure out what our baseline performance measures are, what we're looking to evaluate as outcomes. And then we add on top of that an intervention, and we look at the difference. And that's one of the things that we've done with COVID Tracer is, as you may know, there are a set of 16 standardized indicators that are reported by all 64 jurisdictions for COVID-19. They're related to coverage of interviews, coverage of contact solicitation, and the coverage of notification of those partners, and how fast is that done. And a lot of those are very similar, if not synonymous, to the work that we do in STD and HIV, is that we are looking to ensure that people have access to a case interview. They have access to a partner elicitation interview, and that those partners are notified. Those are standard. Even though I respect what Raul was saying, ultimately it's up to the local level to make decisions on what they decide to measure. There are standard indicators for which we consider disease intervention across multiple infectious diseases to be indicative of success. And those must be defined for STD, at least at a program level, if not at a national level. So at least at the high levels, you know what you're looking for. And then once you have that measurable baseline, you can measure the additive benefit or the enhancement of any intervention, whether it be digital or otherwise, on top of that, such as rapid testing, treatment in the field, all of these things that can enhance timeliness, and that timeliness can then be evaluated. Digital tools are no different, and that's what we have seen with using the models such as COVID Tracer, is that we can input standard indicators, and then on top of that standard practice or standard delivery of these services, you add on a time-based delivery of one intervention, and you measure the difference. It's a before and after analysis. Not to oversimplify, but there are certain things, certain ways that you can look at this very routinely to see if you are making a difference. And again, going back to what Jody and I have both mentioned, the coverage of services related to disease intervention and the timeliness at which we deliver these are so important. And we know that from COVID and transmission, STIs and HIV are not really that different. We need to get to the people infected, test them, diagnose them, and get them treated and their partners treated as rapidly and as completely as we can. When you add on any type of enhancement or intervention that might improve that, you can evaluate that with models or with actual data. And that's what we've seen used following along the epidemiology and laboratory capacity data from the 64 jurisdictions, is that with the increases and declines that have occurred in different time periods with COVID-19, you can measure the consistency or the change in the coverage of these public health interventions. And so at a minimum, I think there's the opportunity to do that. And on top of that, we can look at the enhancements with the digital interventions. I don't know, Jody, if you have anything to add to that.
Yeah, I just wanted to add, so I think we also have a duty to educate our partners about the evaluation process, which we consider the gold standard, versus if you've built something, you bring it to people, they start using it, how do you do an assessment afterwards? This has been an issue overall with exposure notification, because the privacy issue to get people to be willing to use the application, the app, put an app on their phone, getting that trust kind of became the most important thing when building and then having people use it. And this is also a worldwide app, but what you lose on the back end is your ability to gather data. So how do we educate our partners as well about the importance of having something to evaluate or do an assessment on the back end? Because we are going to see if we have another epidemic in hopefully 20, 30 years. How do we get, people are going to bring technology to us to review. Your public health departments are going to be overloaded. How do we teach our partners, please, you need to have this, even if it's not the metrics, we can't control every metrics, we can't see into a crystal ball. That education is also important on the partner end.
Thank you. I have one last question, which I'm going to address to all of you, and I'm going to come to you one by one for the answer. And my last question is, this is going to be a huge job. What is our first step? Next Monday, after the weekend, we have to start working on this stuff. what should be the first step we focus on? And Tom, I'm going to start with you.
Well, I've learned a lot the last couple of days, and I think I just want to have sort of a comprehensive inventory of what's going on and how programs have used existing technologies, developed new ones, to try to get a sense of where people are innovating, what they're doing, and then step back and see if there might be ways to suggest ways to multiply the force of what has already been done. There are plainly some synergies. There are areas where some programs have done things and learned things that, if applied to another area, might have a big impact. And we can begin to think about the possibility of suggesting ways that individual health departments might try some things in some jurisdictions. And of course, the stock answer, more data.
Thank you. All right, Ryan.
Yeah, I too have learned an awful lot over the last couple of days, and it's been very interesting to hear from the variety of speakers. I mean, it's a big task ahead of us, and I think that yeah, I agree with Tom. I think that to sort of take stock of what programs are trying and sort of what is possible, you know, just I think it's gonna be very important to to just sort of think through that and how it might be implemented across jurisdictions. And I think that from my perspective, yeah, I mean, like understanding your policy environment is going to be very important to make sure that you are still acting within your authority, and that, sort of as you're thinking about implementing these new policies or new practices, rather, making sure that you're not like at the end of the process before identifying policy issues, just sort of getting out in front of it and making sure that that path is clear for you before you get too far along. Because I don't think any of these policy barriers are insurmountable. I think it's just important to give yourself enough time, because sometimes it can be very resource intensive and take quite some time to get through this. So I think to just give yourself time to be thinking ahead is wise. So.
Thank you. So Laura?
My head is still spinning from everything yesterday and the day before. There's a lot going on. It seems that one approach could be to really, systematically look at where we can synergize with what is happening with COVID, and where I guess would be the highest yield to invest or to focus on from that perspective. If there's momentum going around the technology piece, and where does it make the most sense there? I think that the regulatory issues are important, and whether that be jurisdictional policies, Dr. Vanderpool didn't really have time to get into it with her presentation as much yesterday, but I think there are some areas there that we may need to address around, self-collection, around how we are regulating our new testing technologies and potential barriers there as well. But to me, that and then as Ryan said, outlining and this is where I think Ryan's already volunteered DSTDP to help for this, but like systematically looking at what the different policies are in the jurisdictions to help jurisdictions navigate some of this as well, in terms of what is possible. Like, what was presented yesterday by Dr. Galoob about her, the fast track program is incredible, I think, in terms of what, how the IS are being used in that, or to expand services. And I think that is not necessarily going to be something that every jurisdiction can do, but, are there ways to, define where jurisdictions sit right now with that, and then help facilitate those conversations, or at least, as Ryan mentioned, training around that, so that, some of these different programs can be implemented. Because I think everyone's probably at a different stage. So I don't know if that all made sense, but that's kind of what my thoughts are when hearing that question right now.
Thank you. Raul.
Well, I agree with everything that Tom, Brian, and Laura said, but I think that the meeting actually helped us understand how little did we know about how the functions and the work of DIS changed during COVID. And this has opened my eyes to all the innovation that is already happening out there. So as a first step, I think we should actually take a very detailed look at what's happening in all the jurisdictions that our division is currently funding. And I think the DIS funding, the new funds for the expansion of the DIS workforce is giving us a great opportunity to actually look at how jurisdictions have implemented DIS work and how they're planning to enhance and expand that work to meet the needs of their communities. I think in the next few months, we'll have great opportunity to engage with all the jurisdictions and understand how this DIS funding is actually going to be used and begin to define how we may have to modify our metrics and the outlook and the targets for the DIS work. So I'm looking forward to it.
Thank you. Jody and Melanie.
So I have an idea. So I kind of recommend the US Digital Service as doing a discovery sprint where you talk to your stakeholders. I think there's a way where you have to zoom out and have someone else ask the questions while you observe and speak to the states about their experiences to see what their experiences are without our own bias. I think sometimes you have to zoom out, take an evaluation. The discovery sprint is a method of understanding the status of your complex systems as they are right now. And I think that may be a good overview, and it's a short process. It takes less than 3 months. And I think that may be a way to go to at least, while you're doing all your other work, have that go on the background and have a write-up of that work. I've worked with that group before. The work they do is excellent. And I think customer discovery interviews, asking those open-ended questions, discovering those Easter eggs of opportunity that you can't see for yourself is a great place to start.
Thank you. Last but not least, Melanie.
Thank you, Sevgi. Maybe this is the appropriate time to say again that we have the opportunity to look at the experience with COVID-19 and case investigation and contact tracing. There have been so many lessons learned, good and bad, I would say, and I think it behooves us at minimum to consider what applications and information might be usable. And it's valuable also that I know nearly all of us on the call and those participants that have joined us, thank you, have been part of the COVID-19 response. And these interventions that we're discussing and we've presented as far as digital tools have been experienced now and used by many of us who have been pulled into the response in various capacities. And so we can use this experience immediately to adapt some of our systems and even processes, whether on the ground or digitally, immediately into the world of STD and HIV intervention, tuberculosis, and other public health activities that bring people into care. I think that to me is one of the things that I think we can do immediately, and we should take advantage of this experience, which I think we're still in the midst of, but it does seem like one of the opportunities that we should not miss. Thank you.
Thank you. I am going to say a huge thank you to all of you panelists. You have been a wonderful panel. And I'm sure if we were all in person, we would get a huge applause for all of the panelists who participated in this session. Thank you very much. And we're going to have an hour-and-a-half break. So let's get together again for the question and answer session at 2 o'clock here. Thank you so very much.
Joining us for the question and answer series. See, I'm trying to see who all is on for my questions that I have. I think we will start with a set of questions on DIS training and attributes. Sarah, are you on? Yes, you are. Okay. So the first question is for you. Can you talk a bit about the backgrounds, education, qualifications of DIS that offer fast track services? And are all HIV DIS trained to do this or just specific DIS?
Yeah. So all of the DIS staff that work within the HIV Bureau, and they're all PHAs, they all were trained to do fast track. We actually had folks were trained on all of the different components. So sort of an additional primer on the education and counseling that they did with clients, logistical training on how to do the specimen collection, an additional sort of logistical training that had to do with what goes in what bag and how all of the different pieces go together. And then training on the red cap system that we used in the field to document. And so, I mean, we had a very detailed protocol, and the different training components matched that protocol. But the folks who participated in implementing the fast track program did an amazing job. And I mean, I don't have to tell the folks on this call that like DIS staff are already able to like play the flute and stand on one leg and juggle 6 balls. So it was all good for them.
Great, thank you. The next question is for Lucretia, and it was, how was training the DIS staff organized and conducted?
Good afternoon, everyone. So with the staff that work with us in the New York City Department of Health, they're not all quote unquote they're not in that title. They're either public health advisors, public health epidemiologists that work in STI, HIV, communicable. And so they're trained, like for COVID, you know, in their regular bureaus, they might have a DIS training and doing that. But what we do when we're activated for outbreak responses, we train them on the emergencies. So we've had maybe 10 years ago, too long ago, we had a big training for all the DIS staff, all the EPIs and advisors, training them on basic EPI, how to interview, outbreak response, and we need to do that more often. But during any activation, we have a whole set of trainings going anywhere from the specific disease, what is needed for the investigation, for oh, I'm sorry. I just realized my camera was off.
Okay.
For the individual investigation, what is needed, the illness, the database, how to enter and what's needed in Maven, the questionnaire. So we set up trainings for that. And we have constant trainings. We had like a refresher once a week, a training time that we have different topics each week. And if anyone had a question about anything on the outbreak response, they could ask it then. It was constant training and retraining as protocols change. We also have very in-depth and specific protocols that we have that is given to all staff.
Thank you. The next question is on testing, and it's for Bobby. So when should we use antigen, antibody, or molecular tests?
Well, it's a great question. It depends on what you're doing, and it depends on the pathogen. So obviously with viral pathogens and with syphilis, antibody tests can work great to tell us if they've ever had an infection. Antigen tests are great if you want to know if somebody has an infection right now, but usually works best only with symptomatic people. And then molecular tests work great if you want to know if somebody has been exposed and possibly has an infection right now. So it really depends on what you're doing, and especially if you're taking it into the field. Most of the field-based tests we have access to right now are antigen and antibody tests, but molecular are becoming available, and so that's the great news.
Thank you. So the next set of questions is on expanding DIS functions. Matt Hogben, see you? I do. Okay, the question's for you, Matt, if you can hear me. What differences do you think exist between routine disease investigation activities and outbreak response?
Right, so can you hear me?
Yep.
I can turn the mute off, but the host has left me blind. Oh boy. So there we go.
Good. Everybody doesn't want to just see my face.
All right then. So let's see. Can you run that question? This was about differences between routine investigation.
Yeah, an outbreak, and also how it affects the team composition.
Okay. So let me start this one off, and I believe there is a fair number of people who actually manage DIS programs in this, and perhaps you guys would like to comment on that issue as well. It's not so much that I would expect wholesale differences, but I would expect, of course, in an outbreak, concentration of resources, right? And that would be of personnel, and that would be of dollars in this country as well. So one sort of area you would begin with, right, is we talk about a concentration of resources, of course, but you've got a finite pool of resources. So if you're pulling from one, if you're putting into one area, you're almost certainly pulling from another. And I think it's a true story for just about every program, and it certainly is up at CDC as well. So as you begin that concentration of resources, I think I would be thinking about what changes in prioritization am I likely to make. So if you're in a program where you say, I prioritize pregnant women for services, or I am in an area where there are dense sexual networks of men on it, those will be my normal prioritizations for it. And those might change well, probably quite plausibly would change in the course of a disease investigation. And maybe that concentration, that prioritization would be geographic, for example. I've thought about this a little bit, all right, and I'm going to defer to people on the real details here, but I would like to say the preparation is key. And I'm going to refer back to a program that actually hasn't been mentioned on here so far, and that's SURGE. That's the, let's see, Sentinel program for it, and it's looking at resistant gonorrhea. And Karen Schlanger and Bob Ticaldi, the people who I think who ran that program, they put together a series of, as part of the cooperative agreement, they put together a series of tabletop exercises. And there's actually a pretty recent paper out on the composition of those. And that's preparation, right, for that concentration and reallocation of resources and reprioritization of skill sets on it. So I would recommend that people who are interested in sort of preparing for sort of outbreak response, take a look at that paper, and I believe that we can provide technical assistance on setting that up. A lot of this is also about partnerships and about maybe even, and I think we've seen this with COVID in particular, right, the acquisition of temporary authorities to sort of go beyond your normal purview. There are a whole host of people here, I think, who can speak to what going beyond that normal purview might be. And I was just hearing Suri speaking now for it and thinking exactly of some of those sort of field tools that you might be able to test out, or that you might be willing to prioritize in the case of an outbreak investigation. Last thing I'll say, right? Phase of epidemic or phase of the outbreak is vitally important here. I'm bringing into mind Martin Meltzer's presentation on modeling, and I would place at least a small bet that the best case, best effects for cases averted were when we were at the beginning of the outbreak rather than in the thick of it.
Thank you, excellent points. The next question is for Lucretia again. What is being done with Hep C in New York City?
Okay, so Hep C, prior to July, Hep C, as with all other viral hepatitis, was covered under my unit in BCD, in Communicable Disease General Surveillance Unit. It has since moved. They've created a new division, a new Bureau of Hepatitis, HIV, and STI, and merged all of them. But prior to that, we were getting, providers in New York City no longer had to report chronic hepatitis C. We were getting labs, were reportable, but we were investigating. It was a separate unit too. So it wasn't my EPIs or DIS staff that did these investigations, but they would investigate any acute cases, especially those that look like it might have been nosocomial transmissions, dialysis centers, and such. So it's reportable by labs, but no longer chronic by providers. We also get negative results in New York City. We pushed for that a few years ago as well.
Thank you. The next question is for Matt Golden. How can we best integrate PrEP linkage into APS?
Well, I think there are a few steps in this. First of all, you have to have a place to link people to. So you have to decide, are you providing this in your clinic? Are there other places? And probably the best is that you have a range of options for people. And then the staff need to know where they're supposed to link people, and it needs to be in the interview. And then in our case, we also use this as a monitored outcome. So we monitor the proportion of people receiving partner services who are already on PrEP, the number who are offered the referral, the number who accept the referral. The hardest part to monitor is that they actually show up and start PrEP. And what we've done in the past with this is we only look at a random sample. I'm not saying that's the best approach, but it is saves some resources in terms of doing it, because doing routine follow-up on every single person would be laborious.
Thank you. The next question is for Laura Bachman. So does having DIS or other health professionals involved in EPT raise the bar? And if so, how should that be approached?
I think it likely does raise the bar, just because DIS will be much more knowledgeable than, you know, the patients, and they're an extension of our public health infrastructure. And so, you know, I imagine that would need to look a bit different than what we would do with, you know, just with sending partner packs or whatever, like through the patient without that DIS interaction. From talking to people in the field about this, and I'm sure there's others that, you know, could share their experience with this, but again, similar to what I brought up earlier, in terms of having protocols, and then, you know, likely would need specific decision points, you know, in case a DIS encounters a situation that perhaps would merit the patient actually going into the clinic instead of, you know, being treated in the field. And I think we all know what some of those situations may be based on the information we put into partner materials. But in this case, you know, we would have a knowledgeable person here, you know, maybe needing to navigate back into the clinic depending on the situation. But so I would think just, you know, probably putting boundaries around the interaction and guidance, and again, the training, and also, you know, having that connection back to the clinic is, you know, we've heard about several examples of that over the last couple of days, but having that ability to be able to connect to the clinic, I think, would be ideal in that sort of situation.
Thank you. The next question is for Sarah again. And actually, Ryan might be able to help too if he wants to add something at the end. So can you talk about the delegated legal authority for DIS to dispense the STD treatment medications in the field?
Yeah, so this was a big thing. This was a huge deal for us. And I will say that, I mean, like, there was a couple of different pieces that went into this. One was that the sexual health clinics were already dispensing starter packs in the sexual health clinics. And what we ended up doing, which I think I talked about a little bit, was registering fast track patients as sexual health clinic patients who were having a virtual visit, but registering them as full sexual health clinic patients in the field. And so the medications, a certain number of PAPs were signed out to the supervising PHA within the DIS field office. And then daily, that supervising PHA would sign a certain number of med PAPs out to the person who was going to do the field visit. The med numbers were tracked and they were entered into the REDCap database and the EMR, and also the ARV med specific med database. And they were all labeled with sexual health clinic labels, and the nurse practitioner, because it was a video visit, was able to see, the PHA held the label up to the video. She confirmed the label, she entered it into the sexual clinic EMR, and then she watched, it was DOT. She watched that patient take that first net. I have super detailed protocols for this that I could share with folks if they're interested, but I feel like that's kind of enough for now.
Thank you.
I would just add that is incredibly interesting. From the few examples I've seen, like actually in state law, it is so not that detailed. So I think it really emphasizes the importance of, like understanding the law on the front end, but understand that's just the beginning of the process. Actually thinking through how you can implement it in your program that's going to be the bulk of your work. Yeah. So yeah, that's very interesting. Thanks.
Thank you. The next question is David Johnson. Oh, there's David. Did I lose David? No, he's here. Okay. So do you have examples of how you engage the community around DIS work? You might be having technical issues. Okay, so I'm going to move back to a question to Matthew Hogben. See you, Matthew. Okay. So what population needs could DIS address during STD investigations? And how would you go about facilitating prevention, balancing sort of the short-term and long-term benefits and costs?
One of the great things you could do is probably see some of these presentations on it. I feel that we're about to sort of like or like rotate around the fast track program as a kind of like looks, but that sort of thing. So maybe more generally thinking, there are a lot of possibilities, right? Can you deliver medications out in the field? Which are your DIS trained, or could they be trained to administer injections, or at least some types of injections? Or maybe get people to if not a clinic, right? I mean, I don't think that's the heaviest lift conceptually, but what if your clinic could collaborate with a host of, say, retail health clinics and sort of CVS type clinics or pharmacies or urgent care centers or what have you. So you sort of expand that web, and then it becomes easier to navigate patients there. For that, you need to sort of the background thinking, right? My job is to assure that this patient gets treated in a timely and appropriate fashion, and that your program's job is to ensure that you have the ability to do so. So I think we will be looking at expanding as much as possible the means for people to get treated, knowing that you're going to reserve, again, like your powder basically for the most for complicated infections, repeat infections, people who are central to infection. You can see all sorts of kind of assessment and how well your program knows the area works into that. But the uncomplicated cases, a person you haven't seen before who needs treatment for, it turns out, maybe even chlamydia, even if you're in the course of a different investigation. I assume you're not out in the field investigating chlamydia, but they don't have to go to a clinic for that, and you've got a list of places they can go, and maybe health department works with them. I think in terms of prevention, there are these sort of basic, really educational messages for it. I think We have had some success in some circumstances, training people in the field to deliver, training them on sort of motivational interviewing techniques and approaches on it that are helpful for eliciting information. So the skills you might use for contact elicitation can also be used to deliver maybe prevention counseling more effectively than just didactically. And I think that also pushes back to the partnerships that the program has and the ability of your field investigators to connect people with those programs. We heard, right, like the warm handoff, the assurance that people reach those, maybe again on a monitoring case, and go and have people at least kept that first appointment, right? And that would apply to, say, PrEP, would apply to other prevention counseling. There are a lot, you can see it sort of expand more and more. And again, the background in there, what are your authorities and sort of what could your authorities be? Maybe we make a plug for research here and say, hey, we're going to know some gaps out of this. This is where we sort of push research to close those gaps.
Thank you. Our next question is for Martin. Lost the question?
Yes, can you hear me?
Okay, yes, I can. Thank you.
All right, excellent.
So what assumption did your model make regarding the proportion of contacts index cases would notify and then go into quarantine in the absence of any public health contact tracing?
So the technical answer is that assumption is built into the model. And I think actually our estimates of impact are on the conservatively low side. First of all, we only count the potential for onward transmission or stopping onward transmission amongst those cases we contact and amongst those contacts that are named and that we can get hold of. And there were some exceptions, but most jurisdictions that we studied in the paper that will soon be published, most of those jurisdictions had between 60 and 70% of reported cases that they actually were able to talk to and get a list of contacts. And in fact, only about 80% of cases named at least one contact. So that's an undercount. So what that really means is there was a lot of transmission or potential for transmission on the table that we did not account for, did not adjust for. And then also we know that there is contact tracing. Let me put it this way. Contact tracing is all about the providing of information to cases and contacts in which essentially we request that they change their behavior. They go into quarantine or isolation as per our recommendations. We can't force them. And again, one of our estimates, we have a lower estimate in which we only include those contacts that agree to go into monitored isolation, which in some places was a pretty low percentage, let me tell you. And then for the upper estimate, we just assumed that amongst those contacts that agreed to talk to us, which is not everywhere, there were some jurisdictions, as I'm sure people can imagine, where basically a contact refused to talk to the public health agency doing the contact tracing or hung up on them after a very short while. But you assume if you had a successful conversation with them as a contact tracing agency, the contact then changed their behavior and went into quarantine. So that was perhaps, you might say, the most fully optimistic. But even then, that's an underestimate because you're not counting those contacts whom you know exist or suspect exist and whom you have never actually contacted for whatever reason. You can't get hold of them, you didn't even know about them. So overall, you end up with just a small percentage at times of the initial set of contacts and cases that you're able to transmit the information and requests, if you will, to go into isolation and quarantine. So there's a large percentage of cases in quarantine that you don't. There is undoubtedly, and I sense it in the question, the idea of a ripple effect where people, without reference to the public health service, notify contacts and tell them, oh, I was a case and you probably should go into quarantine or at least alter your behavior to some extent. I think that's all true, but we didn't account for it, which then comes back to, this is why I justify my statement that I think the estimates are conservatively low. And because we don't know the degree to which people successfully transmit information. If you're a case, how do you tell other people that you're a contact, and how do those contacts who've been told by the case directly, how do they change their behavior? We really don't know that. I noticed in the UK, it's actually, as I said, England and Wales by Wyman-Tuttle, they based some of their estimates on the assumption that when people told them, oh, in the general population, if I was notified that I was a case or been exposed to a case, I would go into quarantine, which seems to be slightly on the optimistic side, but even then they did not have every single case. They used a figure of about 61% of the people would go into some form of isolation or quarantine. So bottom line, I absolutely agree with the point. There is people out there who might change their behavior without the interaction of the public health agency, but those are excluded from the calculations. And finally, if they do change their behavior without us knowing it, that change in behavior is recorded in the number of cases that occur in the community. And we take that into account in our calculations when we fit the curve, as we like to call it. So we don't know the full impact, but if it does impact transmission, it does alter our calculations, reducing them, in fact. Is that sufficient at this point? I think that's probably more than you needed to know.
No, it was very interesting. Thank you so much. Very thorough. Matt Golden, the next question is for you. In Philadelphia, we saw something similar with HIV cases to what you reported in partner services, that it was very efficient early on at finding new cases, but as time went on, it became less and less likely to find a new case. And so originally it was thought that the majority of transmission of HIV was from individuals who were unaware of their status. And the questioner is wondering if HIV transmission is more linked to people who know their status, but the viral loads are not controlled. And they wanted your thoughts on that.
Well, I think it's a reasonable supposition, in part because the number of new diagnoses has really declined. So in many parts of the United States, the epidemic has shrunk. Philadelphia is probably one of those places. Seattle is another one of them. So it would make sense that if there's so many fewer new diagnoses, they probably constitute a smaller source of the new infections, as opposed to people who are inadequately suppressed. Of course, viral suppression is also increasing. I do think that inevitably, as we made progress in the HIV epidemic, the work you would have to put in, or that you have to put in to identify a new case of HIV, increases across the board. So HIV partner services will be less effective. The screening in your STD clinic probably becomes less effective. The testing in all venues yields a lower positivity, and we just have to probably accept that cost. But I think your idea makes sense to me as a partial explanation, at least. I think there are probably some other explanations. I think that geospatial social networking apps have made this work much harder. That many people have sex partners who they really are not able to find. I also think sort of in general, HIV has become increasingly socially marginalized. And so even among heterosexuals, if the patients are living homeless, they're hard to find, their sex partners are hard to find. The entire thing just gets a lot tougher.
Thank you for that. Let's try David Johnson again. I'm not sure if you're able to unmute yourself. Oh, good. Gotcha.
Yeah, I'm here. Yeah, the gremlins got me. The internet gremlins got me.
I know. It's always fun with virtual technology. So there's two related questions. The first is, do you have examples of how you engage the community around DIS work?
Yeah, I mean, actually, there's two examples, and one I'll just give because to give an overview about how tedious this is. And an example comes back to when I worked at Jackson Memorial Hospital as the liaison, the DIS liaison. And so all infections related to STIs, that was my responsibility. And so one of the things that I ended up doing is I worked all 3 shifts of the emergency room, because that's oftentimes where people were first seen, especially around issues of PID. And I did that, one, to introduce myself, and two, it gave me an opportunity to meet the residents, the interns, and the chief of the emergency room. And I didn't go in and say that I need X, Y, and Z. I told them who I was, and I was there to learn what they did and what their challenges were and how I might be able to help them out. And so that took time. Once I was able to establish that relationship and they got comfortable with me hanging out and being around, then they started posing more questions to me. The other thing I had to do, since medical records was an issue of how to get information, did the same thing with medical records, meeting the staff there, trying to find out and understand what their challenges were, how their job could be done a lot easier, and what they would like from me or anyone else when they're requesting records. And then for the laboratory, the same kind of thing. So you can imagine this took time to do. And this is where I say that when I gave my presentation, community engagement, we use that term loosely. This is time intensive, and it really requires a lot of listening. And another example is, did the same thing in Miami, but this time, well before people were doing outreach, myself and another colleague, we were out at 12:30 and 1 o'clock in the morning in the likes of Overtown and Liberty City. And this is during the height of the crack epidemic. And again, the opportunity to listen and just engage, particularly young Black men, where people were not listening to them. And one of the things that they enjoyed about myself and the other colleague was that we came out and met them on their territory. We weren't afraid. We engaged them. And the thing that the take-home message was that no one listens to us. And so, again, that was really phenomenal and really underscored the need of why we need to engage communities.
The second question was, what does success look like as we expand DIS hiring, training, and community engagement?
That's a good question. And the honest answer is, I don't know. And the reason why I don't know, because the challenge for us is we can't do this alone. And what I mean by this, that if the expectation is that we're going to measure success with DIS alone, then we're going to face a tough battle. I think for me, where we are going to be able to measure success is the number of collaborations and partnerships that we have with public and private sector folks within the community that are going to help us address those things for STI, HIV, COVID, and other infectious diseases. But if the thought is that this is something that we can measure success with DIS alone, then we're fooling ourselves.
Thank you. The next set of questions, or I guess there's only one, is on electronic aids. And the first one is for Anisha. Did I say your name correctly? I tried to pay attention.
Yes, you did.
Oh, good. Okay. So someone had asked if the SMS messages are available in languages other than English.
So in the jurisdictions that we implemented, they are implemented in English and Spanish. For other languages, the functionality is available to plug them in and have them selected. We would work with the local health department or community to make those translations appropriately.
Great, thank you. The next set of questions is on cost effectiveness, and Tom Gift, the first two are for you. Oh, good, we have Tom, okay. So please elaborate on the issue of cost perspective. So individual health departments have to justify their budgets, and they have challenges in adopting high cost interventions that don't provide a direct return. And so what would you do?
Yeah, so this is a real problem. The first panel on cost effectiveness in health and medicine from the 1990s said that if you were dealing with an intervention that uses public funds, you should use a societal perspective, which makes sense. Everybody is helping pay for the service. Everybody's costs and benefits should be valued. But more realistically, it's hard to generate a societal perspective analysis. And it was discovered that for the payers of healthcare services, the societal perspective is not really the world that they live in. it's good to know, but the healthcare system perspective is one that the second panel on cost effectiveness suggested be emphasized. That typically includes all medical costs, and it has a longer time horizon. Some payers and some health departments, they want to look at just what costs they incur, and typically the time horizon is going to be really short. We found when we've discussed with private insurers, they're looking at their insured population churning through because they have employer-based health insurance, they change jobs. 3 years, 5 years is about all they want to look at, whereas a lot of the sequelae associated with something like a primary syphilis infection today will incur fairly far down the road. So you cut that out and it really changes the cost effectiveness picture. So I think individual payer perspective analyses can help identify where the barriers to implementation are. And there is a lot of work out there for some things like an early analysis of rapid HIV testing. It took more hands-on time in the clinic, but because the patient didn't have to make a return visit, it was societally cost saving, but it was not so from the clinic's perspective because they tied up staff actually doing the test. This was an early one that required serum specimens. So knowing what the differences are doesn't really get you something. There's no magic wand you can wave and make something cost saving if it's not, but at least knowing what the issues are, it's not for this program, but it is for a healthcare system perspective or societally, can help provide a little bit of impetus for why something should be justified or not, as the case may be. And this is also a problem, by the way, I'll just say quickly, for things like billing. A lot of times local health departments are reluctant to wade into that morass because it is somewhat complex, because a county health department doesn't necessarily keep any revenue that they generate. That being said, it is worthwhile for them to go through the exercise to generate the revenue to demonstrate value of their services, even if it doesn't matter for their individual budget.
Thank you. I have one more question for you on cost effectiveness. So how can a health department produce an estimate of cost effectiveness for DIS on their own without having to, engage in an expensive contracting process?
Yeah, doing something custom that's perfectly tailored to an individual program can require a lot of effort and end up being fairly expensive. But we do have a couple of tools that we've developed in the Division of STD Prevention that can provide some help. One is called the STIC figure, that's STI cost saved figure, and it essentially allows a program to put in the number of cases diagnosed and treated by whatever the jurisdiction is, a state health department, a county health department, and then they get an estimate of medical care costs that are saved as a result of that treatment. And it does include a fairly simplistic look at partner services. And then there's one called Space Monkey, which is STD Prevention Allocation Consequences Estimator. I'm not the one who comes up with the clever acronyms, that's Harold Chesson. But that allows programs to put in the measure of DIS effort, the productivity of DIS, in other words, how many cases they run each year and what type, chlamydia, gonorrhea, or syphilis. And then it gives an estimate of what the impact is for increasing or reducing the budget. And it is based on, in part, one of those papers that I referenced when I was talking about cost effectiveness, the paper by Do using New York State data. So it's literature-based, and we publish the methods, and so it's something that has a lot more weight behind it than just an estimate that's done very quickly, possibly late in the afternoon on a Friday when some stakeholder wants an answer, but then it's not going to be tailored for an individual program. That being said, like most other software titles, you can play around with it a little bit and look at, say, the implication of adding one DIS FTE, see what it might accomplish in terms of reduced morbidity in the jurisdiction. So it can get you a little bit of the way down the track. And then other than that, it's just a question of looking at what's in the literature. We have looked at a lot of things, and others have as well. Things such as screening at 3 anatomic sites versus just urogenital, cost effectiveness of expedited partner therapy. and various other things to get some sort of an indication.
Thank you, Tom. Matt Golden, we had a cost effectiveness question for you as well. So what is the cost effectiveness of your intervention related to other approaches for promoting PrEP? So this was the APS, to remind everybody. And what, if any, role should CBOs play in this work relative to public health staff?
Yeah, so I think that we have not so much done cost effective. We've done some cost effectiveness analyses on these things, but in some ways, I think from a health department perspective, I wonder if it's not more useful to say, what is the cost per person linked to PrEP? So cost effectiveness analyses, and Tom can correct me if I'm wrong, usually convert things into things like QALYs and allow you to compare interventions which are very dissimilar in terms of what they're achieving. And I think we're probably committed to trying to promote PrEP, that our programs have made a decision that this is going to be a basic activity. It's included in the AG. And so it might be easier for us to measure what is the cost per person who initiates PrEP, or what is the cost per month of PrEP support for somebody who's on it. That's a lot simpler than doing all these things that a real economist can do, but people like me can't. And probably people like most of the people.
Like most of us, yes.
Right. So I think, to me, when you get to something where you say 1 in 3 people who are off of PrEP will initiate it through this intervention, that's extremely cost effective. In terms of giving this work to the CBOs, I guess one challenge with it is we have not traditionally given the names of people with STDs to CBOs. I think Chicago does maybe do some of that, although I'm not positive. So Dave Kern may be able to address that. So there would be a significant legal issue that would need to be surmounted. And so I'm not sure that necessarily is the way to do this. Certainly, if a CBO operates a clinical entity where they already have the people's names, like Howard Brown, then it makes sense they could do it.
Thank you. Our next set of questions are about laws and accountability. And so the first 2 questions are for Ryan Kramer. So the first one is, what can a program do if it wants to implement expanded field services, for DIS, but lacks the scope of practice laws that would facilitate work by DIS?
Yeah, so this could be a sort of long answer, but I think I'd rather sort of address it with just sort of a first step that I think might be useful that programs might not have thought about. If you don't already have a relationship with your state's medical board, that could be really helpful. On issues of scope of practice, standard of care, physician conduct, and so on, they are your experts. It's their bread and butter. Aspects of scope of practice might actually be within their rulemaking authority, but even where it's not, they're going to understand the policy environment surrounding these issues. And they're also going to be considered a credible voice on like what is a good idea for the practice of medicine in your state. So furthermore, it's not a bad relationship to have for a program for a number of reasons. Medical boards can be instrumental in promoting EPT. They can be persuasive in terms of expressing the importance of adhering to your state's prenatal syphilis screening laws, standard of care. It's a good practice. It's a good relationship to develop. Yeah. So for this and a number of other issues.
Yeah. The second question is, as a non-policy expert, how do I go about identifying relevant policies in my jurisdiction?
Yeah, so as a non-policy expert, DSCDP is available for your policy TA. You can email me. Part of what I wanted to emphasize with my talk was that these policies really are pretty accessible in the sense that I don't think it's an especially technical area of law. So if you have any level of comfort in looking through these, through your state code, I would encourage you to, because I think it's a good idea to just, like, even if you don't really understand it fully, to just get a lay of the land. But I understand that might seem, too much. So we're here to help. I'm not your attorney. I can't provide you legal advice, but if it's a matter of just pointing you in the right direction and identifying relevant policies, something factual, this is just policy education. We do this all day long. That's totally fine. When it comes to interpretation, advising you on implementation, these types of things, that's sort of a different discussion that we can work through the parameters of that, and we can point you in the right direction for resources that might be able to help you with that. So yeah, feel free to reach out. If you have a little bit of time to wait, my presentation was built upon a completed policy analysis. I pulled all these policies. I'll be writing up the analysis. Once published, it'll be like the sort of the categorization of states, the text of the laws that'll all be available for your viewing. And it's my hope that we can get it into the special issue that's associated with this meeting. So the point of this paper is really to do just this, to help support your jurisdiction's policy capacity, your policy development. It's an extension of my talk on Wednesday. And honestly, I just, one more plea. I would like to hear from you on this. So if you need help, I'd love to hear your thoughts, because I really want this paper to be useful to the field, and to the extent that programs have already been thinking through these issues, have addressed aspects of it already. Your feedback would be really helpful to me. So I hope to hear from you. So,
thank you, Ryan. Raul, the next two questions are for you.
Hey.
Hi, so we have matching backgrounds. So I stole it. Should we be focusing on improving program performance or program impact for accountability purposes?
As I said on the previous panel, for accountability purposes, I think we should be focusing on program impact. However, given the complexities of the program we're focusing on, which is actually the work and the functions of the IS, I think it's extremely difficult right now we don't have the right metrics to actually assess program impact. We do have some performance standards for the IS work. But again, we need to keep in mind that there are a lot of difficulties in assessing what the IS is currently doing. We have variability in the access to technology in different jurisdictions. We have geographical variation. We also have variation in number of DIS per population, and how different programs are implementing DIS work. Most states have the DIS activities embedded in the SCD program. So when we talk about program impact, are we trying to assess the impact of the SCD program or the impact of DIS activities on population based indicators and population based outcome? And I think that's where we have some difficulty. I do agree that we have performance standards, we have performance metrics to assess the work and the productivity of DIS, but that doesn't translate in impact assessment.
Mm-hmm. And so tagging on to that, what are the targets for DIS functions and who should be setting them?
I think, like I said earlier, I think the targets for DIS functions should be set locally. I don't know what they are right now because we have to assess exactly what DIS will be doing and whether they will have enhanced functions. We do have targets for SCD programs. We have the National STI Strategy has targets, and we have targets at 5 and 10 years from the implementation of the program. We also have targets that are focused on disparities. So targets are and do exist for the SCD program. But I don't think we have any targets for the IS work or the IS function, and that's where the conversation is to start.
Thank you, Raul. The next questions are for Anna Cope on this topic. Hi, Anna.
Hi.
So is there any research on the effectiveness of contact tracing and partner services for hepatitis C?
I think there is some, but I don't think there's as much as for STDs or syphilis or HIV, excuse me. I think most of, and I can speak locally here in North Carolina, our DIS, our hepatitis program, hepatitis disease is investigated by our local health departments, and we do have a number of hepatitis bridge counselors who are trained as DIS and who in theory can perform the role, but they don't necessarily do all of the work, all the case finding work that DIS do. So I think this is an opportunity for further reporting of outcomes related to contact tracing in hepatitis. And I do think that our DIS do get pulled in when there's outbreaks in hepatitis C, as well as with other diseases and that other outbreaks that occur in our communicable disease branch. So there's definitely less information about the contact tracing outcomes, but I think there is DIS-like work being done for hepatitis C.
There's one more. Are standard performance metrics, so contact index, treatment index, still useful in measuring the impact of DIS work?
So I think they are, in that they are, very well-defined measures that we have calculated, have historical analysis and can be calculated fairly easily by most programs. So there's definitely value in continuing to use that, and they do provide information about what DIS are able to do. I think they maybe shouldn't be looked at alone. There should be other other thoughts about how can we improve these metrics or add to them in order to fully understand the impact of DIS work.
Yeah, thank you. So we did have one more question that came in that's probably open for multiple people. So I guess jump in, or I'll start calling on people. The question was that they want to know how jurisdictions were able to send SMS messages informing about positive results through exposure notification system, because it was vetoed by the legal team. And I think that's what Ryan was saying before, like he can give you information, but your own legal team is going to tell you if you can legally do this or not. And so, they can only receive a link that says your results are available, and then you have to go to a portal to access it, which results in low rates of notification. And so can anybody address that question?
I'm not sure I can address it specifically regarding the permissions that were required. And I was looking to see if David Kern was on the line too, because they had a robocall system. It was very similar to what we have in Maricopa County, where again, within 24 hours of a positive test result occurring in the laboratory, you were notified via your cell phone. I think it had to do with the leaving your notification or the locating information you provided along with that laboratory test and the method that you approved to receive results. But also I know that every single person in Chicago during a certain period of time, and they received a robocall as well, similar to what was done in Maricopa County. But I don't have the information on what the legal parameters were of that. Only that digital tech.
Yeah, I can tell you, we also send a text message to everybody, all cases, before they get their contact notification call, to tell them you will be expecting a call. And it also offers them some linkage information to services related to things like groceries and services that some people need. And I think, I don't remember the specifics of it, but it did go through legal. I mean, we are legally empowered to investigate cases of communicable disease and to communicate with these people. So I think the feeling was this is part of our public health charge. Ryan may have a better sense of this than I do, but I think it was the general communicable disease law permits us to do this.
Yeah, that sounds right to me. I think that part of the snag here, and this might be too technical for this conversation, but I do know that SMS, text messaging, is not considered a secure platform for communicating health information, protected health information under HIPAA. So when you're talking about actual results, I know that there's a very strong preference for sending a link that sends you to a secure website. which that's probably what they were getting at. So I think that contact notification is a little bit different because that's a public health communication. That's not necessarily under HIPAA, depending on how your health department is structured. But yeah, listen to your legal department.
Yes. Ilaria, did you? Yeah.
Yes, I wanted to basically say similar what Ryan said, is that SMS is not very secure and can be easily intercepted, and that's why probably was sent to a secure website. Is also part, is also important the fact that they were decoupled so that the information wasn't sitting on the phone for other apps to actually access it. And that's probably why it was sent also to a website for the different types of information that different apps can access on the phone. You don't want to have it sitting there.
Thank you so much. We don't have any more questions, so I'm going to pass this along to Sophie. I think we have some closing slides. There we go. Thank you.
Thank you. Good afternoon. Here we are at the end of our agenda. I know you were expecting Leandro Mena to be addressing you. Unfortunately, he could not be with us today due to a family issue that came up. So I'm stepping in with closing comments. If I can have the next slide, please. Let me tell you a little bit about next steps. I know in the question and answer box, I saw a lot of questions about, will the slides be available? Will recordings be available? Yes, the recordings of the meeting, including the slides, will be available on NPIN's website as soon as they're all pulled together, collated, and are available for review. That may take a couple of weeks, but they will all be available for you. Secondly, I think seeing the interest in this meeting and all of the discussions, you will be happy to hear that we will start working on a journal special issue based on the meeting as soon as we recuperate. I think all of the presentations have been very well received and really served to close a vacuum in the literature. So we're going to try to pull together articles based on every single one of the presentations that were included in this meeting. And I want to thank all of the speakers for what they have done, but let me also thank them right now for what they are going to do in putting the, oops, can we go back to the earlier slide, please? For the work they are gonna do for the special issue. I know issues around hiring, training, and retention of DIS came up repeatedly in this meeting. And I know we did not pay sufficient attention to any of these three issues. The reason for that was we didn't want to have a meeting which went longer than 3 days. It's difficult to keep on paying attention on Zoom. So what we decided was we would do a focused meeting on issues of hiring, training, and retention of DIS. We will try to put that meeting together as soon as we can. Unfortunately, I am not sure when that can happen, but we will try, trust me, we will try our best to do it as soon as possible. If you have any further comments and questions, please forward them to me at saral@cdc.gov with a copy to Patricia Jackson at send your comments and your questions. One other point, which is not here, you may have noticed that we have been experimenting with different ways of holding these meetings on Zoom. We have tried to minimize time. We have tried to expedite transitions between speakers. We have tried several different innovations to try to make the meeting better. If you have any comments about what was good about the meeting or bad about the meeting, or how we can make it better, not only this meeting, but meetings in general, please feel free to comment on that and send me emails. I will be grateful. Next slide, please. I would like to specifically thank all of the organizers. I couldn't have pulled this together without your help, and you know it as well as I do. All of the speakers have been fantastic. Thank you so very much. Similarly, our panelists were dynamite. And of course, all of our participants, our audience. Until the last minute, you all have been so lively and participating actively. We really appreciate that. On the part of Dr. Leandro Mena and myself, I'd like to thank you all very much and wish you a wonderful weekend. I think we all deserve it now. Thank you.